Today the discussion will be on keratoconus. Before going into what is keratoconus, we will go to the definition of keratoconus. Keratoconus is defined as a clinical entity which is characterized by non-inflammatory and non-infective progressive bilateral thinning of the cornea with ectasia conical shape. Looking into the introduction, it is usually a bilateral condition. The age of onset will be around the age of puberty. The severity varies from mild irregular astigmatism to severe thinning, protrusion, and scarring. It is estimated that the annual incidence of keratoconus was 1 in 75,000 and the prevalence was 1 in 375. In India, it is estimated that the prevalence of is 2,300 per lakh population. So etiology, the definite etiology is not known. The pattern of inheritance is variable. There are various theories behind the development of keratoconus. One is the enzyme theory. The enzyme theory states that there is increased epithelial lysosomal enzymes, decreased alpha-1 proteinase inhibitors in the epithelium, and also there is decreased P6PD in the epithelium. So the etiology will be eye rubbing, where the patients who are having constant eye rubbing. Constant eye rubbing will be seen in cases like BKC, atopic diseases, Down syndrome, Leber's retinal degeneration, contact lens wearers, whereas these people will used to have a microtrauma in the cornea, which is responsible for development of keratoconus. Also, other abnormalities like connective tissue abnormality and hormonal theory states that the manifestation of disease is common in adolescents. So what will happen due to eye rubbing? Due to eye rubbing, there will be increased tear levels of MMP13, IL-6 and TNF-alpha. So genetic association with keratoconus are LOX gene, ZNF469 gene, which is seen in brittle cornea syndrome, TGF-beta1 gene, which is seen in epithelial stromal corneal dystrophies, visual system home box 1, collagen 5A1. Then associations of keratoconus are, it can be an ocular association or it can be a systemic association. Ocular associations are retinitis pigmentosa, lupus, congenital amaurosis, blue sclerosis, congenital cataract, aniridia, retinopathy of prematurity, Fuchs dystrophy, posterior polymyositis, corneal dystrophy, granular and lattice dystrophy. The systemic associations are Down syndrome, connective tissue and mesodermal dysplasia, Marfan syndrome, Ehlers-Danlos syndrome, osteogenesis imperfecta, congenital hip dysplasia, oculodentodigital syndrome, Rieger syndrome, Clusen syndrome, floppy eyelid syndrome, Turner syndrome, and atopic dermatitis. So these patients, what are the clinical features that these patients present with are? There can be gradual progressive decreasing vision associated with blurring, photophobia, glare, monoocular diplopia, or monoocular polypia. Severe photophobia and watering is seen in cases of eye drops. Particularly, adolescent females are affected. There is conical protrusion of the cornea, the central thinning, and the apex of the cone is usually erected infero-nasally. This is the clinical features of keratoconus. This is known as Munson sign. Munson sign is a V-shaped conformation of the lower eyelid, which is produced by the ectatic cornea in the down piece. This is the lower eyelid where there is V-shaped conformation. Then the second is Rizzuti sign. It is a sharply focused beam of light near the nasal nervus produced by lateral elimination of the cornea in patients with advanced keratoconus. See, we are eliminating laterally and there is a sharply focused beam of light nasally. Then on slit lamp examination, there can be prominent corneal nerves. These were the prominent corneal nerves. And there is something called Fleischer's ring. Fleischer's ring is a yellow brown to olive green ring of pigment, which is formed when hemosiderin iron deposition pigment is deposited deep in the epithelium. Fleischer's ring often becomes thinner and more discrete with progression. Slit lamp examination, how to see Fleischer's ring? It is seen in 50% of all cases. To locate this ring, initially it is made easier by using a cobalt filter and carefully focusing on the superior of the corneous epithelium. Once located, the ring should be viewed in one slide to assess its extent. Then oak striae. These are small and brush-like lines, generally vertical, but they can be oblique. These are found in the deep layers of the stroma and form along the meridian of greatest curvature. They disappear when gentle pressure is exerted on the globe through the lid. Corneal thinning. We can see significant thinning when there is up to 1/5 of the corneal thickness is reduced, and it is stage advanced stages of the diseases. As the disease progresses, the bone is often displaced inferiorly. The steepest part of the cornea is generally, which is the upper, generally the thinnest. In corneal scarring, some epithelial corneal scarring occurs as keratoconus progress because of ruptures in Bowman's membrane, which is then filled with connective tissue. So this is a picture of corneal hydrops where there is a rupture in the Decimex membrane and the aqua seeps into the layers of the cornea and which then reseals. This leads to the haziness of the cornea and the patient will have intense photophobia and blurring of vision. It will be a sudden onset. So it is seen in advanced cases of cornea when Decimex membrane ruptures, aqueous flow into the cornea and recedes. Corneal hydrops will cause edema and opacification of the cornea as Decimex degenerates. Edema and opacification decreases. An increased incidence of hydrops has also been reported in keratoconus patients with Down syndrome. This is the ASOCT picture showing intrastromal clefts and Decimex membrane tears. The retinoscopy shows a recessory reflex. On direct ophthalmoscopy, there is a dark round shadow in the corneal mid periphery due to total internal reflection of the light surrounding the central bright red fundus reflex, separating it from the normal red peripheral reflex. It is also called as Chauliac's oil droplet reflex. These very histopathological findings, which is in keratoconus. Classification and investigations in keratoconus for diagnosis are based on the corneal curvature. We can classify it into mild, moderate, severe, and advanced. Mild keratoconus when the corneal curvature is less than 47, moderate when it is between 47 to 52, severe when it is 53 to 62, and advanced if it is more than 62. Based on the shape of the cornea, we can call it as nipple. When the diameter is less than 5 mm, it is round in shape. This ectasia it is easiest to fit the contact lens. We call it as oval when it is more than 5 mm. It is often displaced inferiorly. Difficult contact lens fitting will be there. And a globus if it is more than 6 mm, where more than 75% of the cornea is affected. The ABCD classification is the newer system for grading severity of the keratoconus. This is recently followed. In this, we have ARC. It is nothing but the anterior radius of curvature, posterior radius of curvature, which is taken in a 3 mm zone. And C is the thinnest pathymetry, and D is the best distance visual acuity. We call it a stage 0 when the keratometry is less than 46.5 diameter and the posterior radius of curvature is less than 57.525 diameter and the corneal thickness is more than 490 micrometer and the visual acuity is more than 20 by 20. We call it a stage 1 when the keratometry anterior radius of curvature is less than 48 diameter and the posterior radius of curvature is less than 59.25 diameter. The thinnest facet is 450 micrometer and the visual acuity is less than 20 by 20. In stage 2, when the anterior radius of curvature is less than 53 diameter, posterior radius of curvature is less than 65.5 diameter, the cornea's thinnest facet is more than 400 micrometer and the best distance visual acuity is less than 20 by 40. Stage 3, when the anterior radius of curvature is less than 55 diameter and the posterior radius of curvature is less than 68.5 diameter, thinnest facet is more than 300 micrometer and the visual acuity is less than 20 by 100. And stage 4, where the cornea is thinnest and is less than 300 micrometer and the best distance visual acuity is less than 20 by 400. The anterior radius of curvature is less than 55 diameter and posterior radius of curvature is more than 68.5 diameter. And scoring will be present in almost all cases. So diagnostic in keratoconus, the patient is coming to you with keratoconus. What are you doing for? First, we do a slit lamp biomicroscopy for the patient and we do refraction. Then the imaging modalities will be corneal topography and tomography, anterior segment OCT, confocal microscopy, and corneal biomechanics. and we'll do genetic analysis, which is genomics. Then corneal topography, where we have classical disc-based principle, which uses first Purkinje image. In normal patients, it will be placing as a with equally spaced symmetrical rings. In case of corneal astigmatism, it is seen as oval-shaped rings. Aspherical cornea, it is seen as non-equidistant rings. Keratoconus signs in keratoconus are malalignment of the myos, loss of Meyer parallelism, inferior or infratemporal curving egg shape. Here we can see malalignment of the myos. There is no Meyer parallelism here, and there is inferior or infratemporal curving egg shape, which indicates that there is inferior steepening. So it is VKG. VKG is nothing but video keratoconography. It only provides two-dimensional information about the front surface of the cornea, shows only curvature maps. This is the VKG map, and it is showing only the anterior two-dimensional information. Then Ranikovich criteria. The cornea is considered suspicious when Kmax is greater than 47.2 diopter, inferior superior dioptric asymmetry value over 1.2, silky astigmatism is more than 1.5 diopter, skewed radial axis is greater than 21 degree. This is KISA index. KISA index is calculated by multiplying Kmax into inferior superior steepening and astigmatism and skewing of radial axis divided by 300 into 100. If the KISA index is 60 to 100%, it is suspicious of keratoconus, whereas if it is more than 100%, it is diagnostic of keratoconus. This is the OptScan. OptScan uses the principle of scanning slit reflex. This method uses rapidly scanning projected slit beams of light and a camera to capture the reflected beams to create a map of the anterior corneal surface and posterior corneal surfaces extrapolated. Pentacam is a hybrid system of slit illumination system and a sheen flood camera that produces images of both anterior and posterior corneal surfaces to create a 3D representation of the cornea. So this is a pentacam map, which is showing bad map here. Bad map stands for Belling and Russo enhanced ectasia display. If we look into any pentacam map, you can see this is the anterior elevation map and this is the posterior elevation map. And this is the 4-map refractive map where we have the axial or sagittal map. And this is the anterior elevation map. This is the posterior elevation map, and this is the corneal thickness, which is on the classification map. This bad display, Berlin-Ambrosio enhanced ectasia display, will have a graph plotted which it has two things. One is corneal thickness facial profile, another one is facial thickness increase, PTI. The CTSP, corneal thickness facial profile, which has a graph plotted against normal values, and the patient's reading should fall between these two normal values. As well as the PTI, percentage thickness increase, should also fall between these normal values. If it is keratoconus, these values will change and it will fall below the normal range. Here you can see this is the normal range. As well as these pentacam maps are color coded. The colors like green color or cooler colors are used to represent normal area, whereas the red color warmer colors are used to represent the steepened corneas. Then anterior segment optical coherence tomography, focal staining, which is more specific for keratoconus and corneal asymmetry, are evaluated on ASOCT. Swift's Fourier domain ASOCT aids to pick up subclinical keratoconus. It is useful to find the depth of demarcation following CXL, to evaluate decimal steering acute hydrops, to see response to SF6 or CPFA treatment in acute hydrops. This is a post-CXL ASOCT image where you can see the demarcation line between the normal cornea and where the CXL is done. This is a ASOCT picture of corneal hydrops. Here you can see basement membrane defect, the fluid in the corneal stroma, and these are fluid clefts. This is after C3F8 gas injection, where there is been sealing of the clefts of the basement membrane, when the clefts are size of the clefts has also been reduced. So what are the modalities of treatment if a patient of keratoconus presents to do? First, we will be giving topical medications and anti-allergic drops and lubricating eye drops for the patient to get rid of their symptoms. Then we give refractive correction for the patient in the form of spectacles or contact lenses. The contact lenses can be a soft contact lens, which is gas permeable contact lens, or a scleral contact lens. Then if all these fails, then we can move for CXL. CXL is the thing with the corneal collagen cross-linking. If collagen cross-linking also fails, then we can, if the patient is affordable, we can go for ICRS, which is setting the intracorneal ring segments, or topography with PRK or phakic IOL. And if all these modalities fail, then we have to go for keratoplasty. The keratoplasty can be anti-level keratoplasty or full thickness penetrating keratoplasty. This is the management algorithm for a patient who is presenting with keratoconus. The patient is coming with keratoconus, which advise them to don't rub eyes. If any ocular allergy is there, to treat them with anti-allergy eye drops. And if it is a young patient, we can consider CXL, and we can correct the vision with glasses. If the patient is having satisfactory vision with the glasses, then we can ask them to continue glasses and consider contact lenses. If it is an unsatisfactory vision, we can ask for trial of contact lens or single contact lens. The management algorithm. If the patient is unsatisfactory with the contact lenses, then we can go for ICRS if the patient candidate is a good candidate for ICRS. Or we can also consider PTK or PRK or toric IOL. We can give trial of lenses, and if there is satisfactory vision, we can ask them to continue with their contact lens. And if it is unsatisfactory, then we have to finally end up in keratoplasty, which is refractory lamellar keratoplasty or penetrating keratoplasty. The first examination, the patient is presenting the OPD, which has the history of atopy, ocular allergies, treatment either being high risk factors, like Down syndrome, floppy eyelid syndrome, connective tissue disorders, various congenital amaurosis. Examine for evidence of allergic conjunctivitis and dry eye. So we have to give the treatment like first advice we have to give to non-drug topical multiple action anti-allergic treatment. This is a better free guys. And if it is a progressive keratoconus, how will you say it is a progressive keratoconus? The criteria for progressive keratoconus are changing keratometry value, which is more than 1 diameter per year, corneal astigmatism more than 0.5 diameter per year, thinness packing, which is more than 20% per year. So spectacle correction. If patient with low or moderate risk of progression or post-CXL stabilized cornea, spectacle correction 6/12 or better vision with spectacles may be deemed adequately corrected. If irregular astigmatism leading to unsatisfactory spectacle corrected vision, we have to go for contact lenses. Type of contact lenses available or soft contact lenses, which is nothing but spherical, toric, or custom toric, or rigid gas permeable contact lenses. And there can be specialized contact lenses like supercone, rose cake, hybrid lenses, piggyback lenses, or spiral contact lenses. This is the difference between a soft contact lens and rigid glass permeable contact lens. Soft contact lens can be used in cases of minor ectasia, in case of minimal irregular astigmatism, central phone which is not very steep. Newer hydrogels provide better fit, better tolerated, and it is more comfortable. RGP lenses can be used in case of irregular topography with steeper cornea, irregular astigmatism, aberrations which is not masked by flexible soft lenses, conventional RGP lenses to visualize lenses like rose scale K2 ICLC more difficult to achieve a comfortable fit. Soft toric lenses are Optiflex toric, soft tape, hydrophone. And specialized rigid lenses are Roski lenses, piggyback lens system, mini serial or serial contact lens, hybrid contact lens with soft peripheral skirt. These were the images of the contact lens fit will look like. This is a contact lens with central rigid plus soft peripheral skirt. So collagen cross-linking, this is a conventional collagen cross-linking. We use Dresden protocol. Where we anesthetize with topical anesthesia, we'll remove the central 7 to 9 mm of epithelium. Then we'll apply a 0.1% of riboflavin, 5% and 20% dextrin solution every 5 minutes for 30 minutes. Then we will measure the uncorrected visual acuity. Then we expose the patient where UVA light, which is of 370 nanometer, and the energy we use is 3 milliwatt per centimeter square for 30 minutes with continued riboflavin application. Topical antibiotic with soft BCL having been outside community is applied after giving a thorough wash. Then intracorneal ring segments. There are two types of intracorneal ring segments available, which is known as intacts or Ferrara rings. The characteristic difference between the intacts and Ferrara rings are given in this table. Intacts, it has an arc length of 150 degree, whereas Ferrara rings have 160 degree. The on cross section, intacts will look in hexagonal in shape, that is Ferrara rings are triangular in shape. Thickness will be 0.25 to 0.45, whereas in Ferrara rings are 0.2 to 0.35. The inner radius is 6.77, whereas it is in Ferrara rings it is 4.4. Outer radius is 8.1, whereas in Ferrara rings it is 5.6. Then contraindications for intracorneal ring segments. The patient is suffering from any collagen vascular diseases, autoimmune disease, or immunodeficiency diseases. If they are a pregnant or nursing mother, recurrent corneal erosion syndrome or corneal dystrophy, patients on isoretinol, amiodarone, and somatropin, large pupillary diameter if it is more than 7 mm. In keratoplasty, the indications of keratoplasty are contact lens intolerance or poor fit leading to poor visual gain, very thick cornea where other interventions are contraindicated, central stromal scarring, and if there is a potential risk of acute eye drops. So the keratoplasty can be an anterior lamellar keratoplasty or posterior lamellar keratoplasty or your penetrating keratoplasty. The anterior lamellar keratoplasty can be ALTK, automated lamellar therapeutic keratoplasty, or femtosecond assisted anterior lamellar keratoplasty. Then DALK, which is nothing but a deep anterior lamellar keratoplasty. It can be a decimetric DALK or pedicimetric DALK. Then the other option is penetrating keratoplasty. The choice of keratoplasty procedure are DFTK, where the corneal thickness, if it is more than 380 micrometer of thickness point and there is no central scar, DALK, deep anterior lamellar keratoplasty, if the corneal thickness is less than 380 micrometer, but the corner in case of very thin cornea less than 200 micron, if there is an impending perforation and there should not be any desmoid scar. Penetrating keratoplasty may be in case of central corneal scarring. The anterior lamellar therapeutic keratoplasty, the advantage is for smooth, not post interface, less interface scarring, less operative time, less skill required. Whereas the limitation is it is a machine dependent procedure and cannot be done in very thin or very steep corneas. The difference between decimetric DALF and pre-decimetric DALF. Decimetric DALF is also known as maximum depth DALF. A plane of dissection based the decimal membrane best performed by the big pupil technique. The advantage is fast recovery of visual acuity. Disadvantage is it is a steep learning curve and there is increased risk of perforation. Pre-decimetric DALF, where if it reaches up to posterior 10% is the posterior stroma, the stroma has some has stroma is left in the bed. Thereby layer dissection is done. Advantages it can be done in case of heat hydrants also. And the disadvantage is there is less risk of thickness perforation and slower recovery. Comparable visual acuity is seen in up to 30 months of follow in both the type of DALK. Penetrating keratoplasty. The indications of penetrating keratoplasty are if there is significant central scarring, endothelial abnormality, inexperienced surgeon. The advantages of penetrating keratoplasty is the quality of vision will be better in case of penetrating keratoplasty, and no extra instrument or machine is required in case of penetrating keratoplasty. Thank you.